Shiva, one important learning point for the last one as well. Because you remember, can you hear me?
Yeah, I'm listening to you, Shaq.
Okay. Yeah, no, because originally you were thinking about a 35 length valve.
Yep.
In retrospect, I think that might have been a bit too long.
Maybe, Shaq. But Shaq, did you see that the proximal end as well as the distal end was just abutting? It was perfectly the same.
30 was perfect, yeah.
Yeah, correct. But based on my CT measurements, it came to 34 to 35. So I was in the impression that maybe this patient needs a little longer. Imagine if suppose my proximal flare was also constrained at the level of annulus, I would have felt bad. But I would say in retrospect, definitely 30 is probably the correct choice. Shaq, can I have the PowerPoint of the third patient?
Yeah, carry on.
So please carry on with the next case.
Our third case.
Okay, we see the PowerPoint presentation of VSD case, Siva, right?
Our third case is intravascular VSD.
Yes.
A 22-year-old girl diagnosed as midmuscular VSD, and she underwent device closure in 2014 with 5,4-ADO2. The follow-up echo showed significant VSD and abnormal position of the previously placed VSD device within the RV trabeculations. She is currently asymptomatic. On examination, has a 3/6 holosystolic murmur in left fourth intercostal space. Her chest X-ray shows CTR of 55%, mild plethora with the left arch. ECG shows sinus rhythm with PR interval of 180 milliseconds, QRS axis 60, normal LV forces. The transthoracic echo 4-chamber view shows a 11 mm muscular VSD creeping through the ventricular septum and exiting in the RV posteriorly, and the device is faintly seen within the RV trabeculations. This is the parasternal long axis and short axis views showing the same VSD. And we did a CT angiogram which showed VSD mouth in the form of oval slit measuring 14 cross 10 mm. In the third picture on the right, you can see the VSD creeping through the septum into the RV. And this is another image showing the same dimensions of the same VSD. Now, over to a live demonstration.
So, Shaq, if you look at that last picture, and Mario as well.
Sorry, just a question. I didn't get exactly. Was a late embolization of this device?
Show the last picture of the PowerPoint.
Non-diagnosed embolization immediately during the procedure. I didn't get it.
Mario, yes. I will tell the problem. Basically, this patient has got a mid-muscular ventricular septal defect, which in 2014 a doctor felt it was suitable for a 5,4-ADO2 device, and he deployed the device. At the end of the procedure, he has mentioned that there is a small residual flow. But when we saw the patient a few weeks ago, we found that this is basically a VSD with a serpiginous tract along the interventricular septum. Show the previous picture. You can now see that there is a mid-muscular VSD that comes off. It tracks through the muscle and it enters distally, and the exit, somewhere in the exit, that previous 5,4-ADO2 is remaining, and it's not closing anything. But you can see that.
I understand, but it means that the device implanted before just slipped into the right ventricle and remained there because of the trabeculations. But the original VSD is still there, and we can see it very well.
Not only, it's not a VSD with the same place entry and the exit. The entry of the VSD in the left ventricle and the exit in the right ventricle are different, and we call this as intravascular defect. That means it is penetrating through the septum, and it is exiting in a different area. So the Srija has got wonderful pictures.
I have a question. This same VSD has been closed by EDU to 5 by 4. This is the same VSD they have attempted to close by 5 by 4 EDU too. It's a quite large VSD.
Yes, but the device is somewhere in the right ventricle and not in the septum.
Hey,
The-
Shiva.
this was
Shiva,
done.
this is Zaid.
Hi,
Shiva?
Zahid. Hi, Zahid.
Zaid, call me ignorant, but tell me what is an intravesicular VSD?
Just show the previous
I don't
last
even know that.
PowerPoint. The PowerPoint last slide. Zahid, see this picture.
This is
See this picture. There is a mid-muscular VSD from the left ventricular
From
side.
this story, I understand what is a intravesicular device.
yeah, because I think this is, as Mario has alluded to, this is a device that embolize and states because of the right ventricular trabeculation from the right ventricular side, and you have the same ventricular septal defect. Now, I don't know what, I've never read about intravesicular VSD, so please enlighten me.
Actually, the right ventricular exit of this VSD is not in line with the left ventricular entry point of the VSD. Can you see that, Zahid? In none of the planes, the LV entry and the RV exit can be connected. I will show you.
There is a long track
This is a
between
muscular VSD with a long serpiginous tract.
Correct, exactly.
That's what you can call it.
Exactly.
Okay, okay.
Now show
That I
show the live echo. Show the echo big. Okay, now show it, Srija. Srija has taken some spectacular images.
Yeah, this is 4-chamber view, which is showing that the LV is dilated. So we are focusing on the posterior muscular septum. The defect is located in the posterior part of the muscular septum. We can see that there is the previous device is seen lodged in the RV trabeculations. So by echo, I got a measurement of around 11 to 12 millimeter at the left ventricular end of the VSD. So that is the defect with the previous device, which is seen in the right ventricle. The right ventricular side, we are getting around 9 millimeter.
Get the color on this, Srija. Yeah, I want a color flow.
Okay, I'll show it live.
Live, yep. We can see that the left ventricular entry point leads into a sac. The sac keeps creeping down. Can you get it on a 4-chamber view? 4-chamber view without mag. Okay, here also you can put a color. Yeah, you can appreciate that it is in fact we made a detailed analysis on the CT, and this was burrowing through the interventricular septum. I will show that now on an angiogram. Make the angiogram big. Give 30 ml at 18 rate.
Sorry, can you enlarge the angiogram?
Yep.
Thank you.
Ready for angio? Freeze it and get a good quality.
So Shiva, it's a VSD with 2 openings in the right ventricle at least, isn't it?
Yeah, possible, Shaq. Now, Shaq, actually, that pouch, what we are seeing as a longitudinal one track on the right ventricular side is actually freely in communication with the left ventricle. Go inside.
But Shiva, the right ventricular side, before it enters the trabeculation, there is enough right ventricular free wall, isn't it, where you can actually put the right ventricular disc. So you don't have to go into the
go inside. Okay. So now show me that angiogram once again. Get a roadmap of that angiogram. Okay. Put it on the side. Okay. Now get me live and fluoro.
Shiva, can you tell us what is in your mind about what device you are going to use and why?
Actually, I am planning to enter into that sac, Joseph, and then take a decision about what I am going to use. See, now I'm entering into the track. Show me the picture, previous picture. Okay, no, still I may be, yeah, I am not in the.
There's more than two holes then.
Well,
It came out, Shaq.
there's a question for you. What kind of wire is this? Is it the Rumo wire?
Yeah, it is a
And
J.
the right Jacques catheter?
Yeah, it's a Judkins catheter with a thermo wire.
Yes. Right Jacques is the Rumo wire.
It looks like it wants to follow the previous device and not your pouch.
Show, hold it here.
Are you going to establish a circuit?
What is your question, Mario? I didn't hear it.
Well, the question is whether your intention is to snare the wire and establish an heavy circuit from the venous side.
Actually, I'll tell you
or,
what.
or what else?
I was planning to get into this track with a 7 French guide catheter and occlude the origin of this device with a 1412 multifunction occluder device. But for that, I need a very stable position.
So your intention is to put a corner MFO device from a retrograde approach, right?
Yes.
Mario,
Okay.
Mario, would you approach this retrogradely as well?
Well,
Stiff wire.
maybe,
Stiff wire.
but I'm not sure because in this particular case,
I want a
the
7
entry
French.
side from the left ventricle is very, very wide. So I would like to be sure that the device is stable,
Yeah.
hopefully more stable than the previous device.
Can you
This device is very stable.
can you
The
come to
previous
AP?
device is very stable.
Can you
I
come to
agree.
AP?
I've got no clear idea of the
Yes,
left
the
ventricular
device is
side.
extremely stable, but useless.
Yeah.
Sorry, the catheter is king.
You're not worried about the large entry side from the left ventricle.
It is actually very.
Siva.
It's a small entry side from the right ventricle. It's
No,
it's
yes, from the right ventricle is small, very large from the left side.
yes.
So that's why maybe an antegrade approach could be useful, in my opinion, because if you deploy the left disc on the left ventricle, you can test the stability of the device before releasing. That's the reason why I would probably prefer the antegrade approach in this particular case. What
Okay.
do you think?
I agree, Mario. I'm keeping both options open. Since the guide wire position was not very stable, snare, I am going to make a loop, and in that loop, then I will have an option of going retrograde or antigrade, whatever we need.
Yes. Okay.
So
Another
the
question,
advantage of
Suresh.
antegrade is still you'll be able to do left ventricular angiograms a bit more freely
As well.
because this is a challenging PSC, really.
Yeah. I don't think I'd rely solely on TE for this. I'd want an angiogram, so I would add another pigtail if I was going to go.
Yes. Yeah.
My suggestion, why not muscular device? Rather than taking MO4 device with too low, muscular device would be better, no? 12 muscular device from aortic side, less cumbersome.
Yeah, what we'll do is we will I have listened to all your suggestions. Let me put in the sheath across, and then let me see what is good.
This is just for the audience. I would like to add a short comment. When I'm in trouble in understand exactly the anatomy and the size of a VSD, because the angiogram is not exactly perfect, I'd like to get a sheath across it and repeat the angiogram. And sometimes it clarifies to me the real anatomy of the defect.
I agree with
Yes,
you. I
there
agree
is a
with you,
question-
Mario.
There's a question for you from the audience.
Yep.
Hi, Mansoor. I think, I don't know, but I think it's an unfair comment to say the VSD is not clear by angio. The VSD very clear by angio, and especially from the LV side, I think what's not clear is the course of the VSD. So I think we can get a very fair decision about the size, and probably, in my opinion, we don't need to hassle to put a loop. Retrograde and a muscular VSD, it will give you a safety to come back and deploy it, and you can inject at the same
Can
time.
you go to the elevation?
So the decision of how clear the VSD, I think it's there. The size-wise, I think you can make a fair decision from the LV side.
So what size, Mansoor?
Yeah,
What size would you recommend, or
10 millimeter.
10 millimeter muscular VSD device?
Yeah, but so taking into account that they implanted the VSD a device before that embolized and is entrapped somewhere in the trabecula, I agree with you that basically probably this kind of VSD was a regular mid-muscular VSD.
Mario, but
Pictate.
have a see on the previous device. Is not the shape is taken very the good shape, the normal
Why?
shape. I think this device was put across a small fenestration, the RV, and deployed there.
Well, the previous device was just simply too small and embolized.
Keep
That's it. I mean, there's not
keep
a
multifunction occluder 1412
interpretation.
and the 14
in
muscular
my
VSD
opinion.
both ready. About the choice of
wait,
the
wait a second. There's an additional questions for you. Hold on a second.
Yes, I'm definitely in favor of Connor MF because it's a very soft device. Incisors over 12, it has fabric inside, and in intramuscular kinds of defects, intravascular defects, the right side disc will be somewhere. It will create some kind of shape, but it is very, very soft, so it never disturbs. And so we've been using it for some cases successfully from both sides.
table up.
Sir, another concern.
Repeat another angiogram, 20 ml at 18 rate. Yeah.
If you want to deploy it from the venous side, the RIGV approach would be better because it is quite lower down as well as anteriorly placed like that or post-MI VSD with sinusoidal tag. So from the femoral vein, it might jump out.
Okay.
It's a bit in the middle, isn't it? So either approach could be feasible.
Okay.
So,
So-
Mario.
Yes.
Here's, hang on, Shiva, stop talking. Mario, I was going to ask Mario, because he wanted a sheet
14,
across
12.
and then an angiogram to clarify the
MFO
pictures.
cable.
Yes. Well, I think this angiogram, well, if you can magnify it, is going to be useful because this sheet across is almost closing the hole, so the real hole is not that big. There is still a substantial hole, but not huge.
So do you think there's a whole...
But I think that making a circuit and going from the jugular vein to the defect should be better because you have a straighter course to the septum.
And
Because
where the sheet
there is a band, there is a 360 band on the sheet across the VSD. This is disturbing me a bit.
And where the sheath is, about a centimeter below on the screen, I don't know yours. Is there another hole there, do you think, that's slightly bigger?
Well, I don't think so. We can repeat the angiogram.
Repeat, show that angiogram again.
Echocardiogram.
Yeah, just show the angio.
Show the angio.
Show the angiogram and maybe show the echo as well. You're loading an MFO device, if I'm correct.
Yes,
Siva.
sir. Yes,
Is that
Mario.
right?
Yes, Mario. I am leaving a wire maintaining technique, which means I am having a wire parallelly.
Yes.
And I can
It's a coronary wire, yes?
not a coronary. It's the same thermo wire.
Oh, that's the terumo wire.
Yeah.
So he's taking just to somebody which is not really familiar with the safety wire. If you have a sheet large enough, you can keep a wire inside in order not to lose the circuit. When you deploy a device where we are not happy, you keep the wire and you can retrieve the device, re-advance the sheet without repeat all over again. That's the key.
What
issue.
size sheath is this, Shiva?
It's a 8 French.
Yeah.
It looks like the curvature that Mario was worried is gone now.
Yes. Thank you. Well, this is the corner MFO device. What size?
It's a 1412, the largest.
1412.
Get
1412 is
get
the largest MFO
Angio-
device available.
Angio ready?
The disc, the left disc is probably 22.
No, it is 18. It's 18. It's 2 millimeters
No,
on either side.
No, it's 20. 14 plus 6 means 20.
14 plus 4. 14 plus 4. It's only 2 millimeters extra.
So you already deploy in the septum, yes?
Yeah, fluorostore this. Show this. Fluorostore, show this.
I think the echo would be helpful too.
Yeah.
Echo parallel. Echo parallel.
Would you mind to show us simultaneous fluoro and echo, please?
Yes. Now are you seeing the, show the echo? Yeah, both. Now you look at the color
Very
flow, Srija. Yeah. So
Can you put the echo larger for us?
echo large, echo bigger and fluoro small.
There's still a lot of color flow
Yeah.
across this.
I will now take out my wire loop.
Do the angio first, I would have thought.
Okay. Okay. Angio now.
Well, that's okay to me. I think the color mapping is probably too pessimistic.
Get a good quality angiogram now. Give 25 ml at 18 rate. Srija, you concentrate on the echo.
Do you want to push the right ventricular disc in a little bit, just because it's stretched out at the moment?
Yeah, but Shaq, the alignment is going to be difficult because I am coming from the tricuspid valve.
Yeah, but as much as you can, really.
Okay. Now,
But there's a lot of tension actually. But the left disc looks all right. Look in the right spot. Joseph, what do you think?
I think the flow is mainly through the device. It's, because it is stretched at the tail end. So because the right ventricular disc is not closing fully, so that's where you're seeing the flow. But it is well placed, I think.
And it
Joseph, I am happy to release. What do you feel?
Yeah, I agree.
It looks secure.
And the right disc is embracing the previous device to some extent. The sandwich technique, Zaid said.
Of closing particular VSD.
Yeah. So you've got no choice. Oh, there you go. You released it.
Show me another angiogram, a good quality angiogram, 25 ml 18 rate or 23 18.
So you stabilized the whole device which was already stable.
Yes.
Yeah.
Very good. Excellent.
So we have another 30 minutes. Yep.
Shiva.
Yep.
Just if you, we can't see because your picture is covering the right ventricular apex. Now that's better. So what do you think of the flow, whether it's through the device, it's worse again, through the device into that right ventricular apex region?
I feel that there is some exit there, but now I have closed the entry. The entry is now having a fabric which will take a little longer to allow a complete closure. Srija, how is the color flow now?
Just keep playing that, Vinny.
Keep playing the angio also on the side.
Well, hold on a second, Siva. There are questions for you.
Yep.
Hi, Siva. It's Amal from Egypt. Do you think now that the first device was not embolized, was actually in the exit of the VSD, but it has multiple exits, and now that you close the entry, then it's closed? Because I cannot believe the device embolized and stayed there.
I agree with you totally.
Question, please. Can we have a view on the tricuspid valve, and is the RV disc somehow entangled to the tricuspid valve chordae?
Okay. Srija, tricuspid valve?
Four-chamber, yes. Sure,
Yeah.
Yeah. And
Srija, rightward rotate.
Yeah, yes.
Now color the tricuspid valve.
Okay. Looks nice, yeah.
Shiva, can you show the angiogram before you release the device?
Sorry, I have already released, but I will show you again.
It's too late.
Show the angiogram.
The recorded angiogram.
He just wants to see the angiogram, Shiva.
I think the device is already pulled into the VSD. If you see the wall on the left ventricle where the contrast is, device is already
freeze it
the
when.
right side. See that? It's fairly deep inside the VSD, the left disc. I think a stiffer device, as recommended one of the panelists, would have been at least better idea. I think the previous device embolized because it was very soft, ADO2. This is a softer device. I think the VSD, regular VSD device with a longer ways would have been a much better idea. I think this is already pulled in, and this shunt may not go away, but you can evaluate 6 months from now.
Zahid, one of my concern about using a traditional muscular VSD device was while the left ventricular entry was quite big, the right ventricular exit was not so large. So if I end up with a very significant restraint of the mid waist to a very small diameter, I will have a dumbbell of LV disc on one side and RV disc on another side with a very tight constriction in between, and this was my concern.
Shiva, if there was a bigger device size in MFO, I would say this would be okay. I think this device, based upon the size, was smaller for your defect, and that's why it's getting pulled in because of a lot of tension by the proximal disc.
Yeah, but Zahid, actually the device has been designed in such a way that the left ventricular disc has got a fabric inside, and the fabric promotes further and further closure within the next maybe 24 to 48 hours. I am actually happy with the current. Show the angiogram, not our face. Okay, now you freeze it when the left ventricle is nicely filled. Little bit more contrast. Let me see once again. I feel that since there is a left ventricular contrast, left ventricular entry is with a fabric, I feel it probably should result in a good picture. But let me show you another picture now that it is another 3-4 minutes. There is another one more case that one of my colleague has already started in the other lab. It's a very interesting perimembranous VSD in a patient who has a right aortic arch, aberrant subclavian artery, and from that aberrant subclavian artery a PDA was also there, which in another center was device closed without causing any airway obstruction in the past. Now the patient continues to have a perimembranous VSD with a significant shunt. Now, so I will do this angiogram and then I will move on to the next lab. We have roughly 25 minutes to go. So hopefully okay, now get ready, 30 ml at 18 rate. Just a second, reduce the ectopics. Okay, ready? Zahid, you see that?
Yes, it's almost close. That's very good result. Congratulations again.
Thank you. So, as I was mentioning to you earlier, there is an extremely interesting patient on the other lab. I am.
Yes,
Shiva.
Yep.
hold on a
Shiva,
second.
stop,
Hold on a
stop,
second.
stop
There is
talking.
a final question for you.
Get this CX50 there.
Pablo's got a question.
A quick question about the technical aspect. When you use this safety wire, it's worth to use one sheet above
One French larger.
One French larger.
Even
for the regular muscular devices. And the other question is if you chose a regular muscular VSD device, would you go for a 16 or 18 device? Just like an unplatzer or...
I totally agree with
Go
you.
on, Shiva, you're dying to answer.
The recommended sheet for 1412 multifunction occluder is 7 French. So we used an 8 French sheet so that I have room for the wire maintaining technique. And since I was analyzing the CT scan, the right ventricular exit was pretty small. So I thought that Conar MF device is a better choice than muscular VSD device.
Okay, you're going to start with the last case for today, Siva?
Yep, last case for today. I wanted their vascular access.
So whilst you're doing that, Zahid, can you answer the second question from Pablo?
Hello.
I think smaller device would be for muscular VSD because the disc is 8 millimeter larger than the waist.